Pleased to have everyone here today. People are joining in. We can see them all rapidly joining in. So please, the first thing we like to do is welcome everybody and let everybody know who's here. So if you could advance, please go to the chat. Make sure that you set the chat to everyone and let us know who you are and where you're from. If you're from an OHT or if you're from another organization, let us know. Great. Oh, Jillian Paul from the Ministry of Health. We have people from high state standards today. Lovely. Welcome, Joe from North Simcoe. Mike Hindmarsh, first to jump in, second to jump in, right behind Kim McKinnon. And here we go. Western York, Marissa Bellenino. Thank you very much for joining. Lindsay Henderson from Northumberland. Welcome. Welcome, Casey from Welland and McMaster Fit. Welcome from that's going to be the Muskoka, Ontario Health Team PFAC, Sandra Holdsworth. Welcome, Sandra. Really helpful. We have decision makers, we have OHTs, we have patient partners here joining us today. Welcome, and we got a great lineup for you today. We're going to have actually a really great opportunity to review the past year of learning health systems, and then really to engage with you all quite a bit. I'd first like to acknowledge the land. I'm speaking to you today from the University of Toronto, and the University of Toronto operates on land that for thousands of years has been the traditional land of the Huron-Wendat, the Seneca, Mississaugas of the Credit, and today it's the meeting place and still home to many Indigenous peoples from across Turtle Island. We're grateful to have the opportunity. I am always grateful to have this space as I ride across the city. I pay attention to Dundas as one of the very oldest Indigenous pathways. I ride along there for a little bit and then up to college. And I know that these traditional pathways have been in place for thousands of years. And I use them now, continue to use them as I ride my bike across and think about the landforms that we've mostly poured concrete over and think about what it was used to be like. So I'm appreciating that. I want to know, on the next slide, we're just going to have our first poll. Welcome to those who are still joining. If you're still joining, please let us know in the chat who you are and where you're from. And we're going to go to this first poll on whether you have joined us before. So please just click in to let us know if you have participated before or whether this is your first event. And I am always pleased that we can be continuing to welcome new people. And that means we're finding new people who are interested in participating. And also that we are continuing to have many, many people coming back again. And now with almost everybody in, could we share the results back out with our participants? And we have, so 72% of people have already participated before, and we have 28% who it's your first time joining us. Welcome. I am Walter Wochis. I'm the Principal Investigator for the Health System Performance Network, and we host these webinars every month, primarily for an OHT audience, but many others are welcome to join. You can take the slide down now and maybe go to the next poll, which is asking us, well, actually, we just could leave this. I meant just to move to the next slide, sorry. We can go to the next poll though first. And this one is going to let us know where you fit in terms of the health system to get a little bit of a sense. I could tell a little bit from some of the people who were joining and the people coming in. If you can just let us know what role you play. Are you a citizen patient caregiver? Are you a clinical leader or a professional, health professional in the system? Are you an organizational leader? Are you a researcher? Or are you somebody else joining us from somewhere else? And Sandra, you're from the Ministry of Health PFAC now, not with the Muskoka after 5 years. So welcome from that perspective as well. So here we have people coming in to join us. Seems most people have weighed in. This should be a question that everybody can answer because there is another option. So we're going to maybe pause for a few more seconds because sometimes we have I think we have about 75% of people have responded at this point in time. We're going to try and get it up to everybody so we know all the corners of the room and who is joining us here today. And okay. It seems to have petered out. Maybe we could share this result back out. So we have mostly organizational leaders, but that's only about a third of our audience, just over 1/3. And we have all of these categories represented: citizens, patients, professionals, as well as government agency, and other project manager. I would have put you in as a system organizational leader, Rebecca. Thank you for joining us today, because I think you're probably leading some very good opportunities there. Oh, the results aren't showing yet, so there we go. I can take care of that. Oh, now everybody can see and hearing them across the way. So I am keen now to move on to the next slide, where I'm going to spend just a second reviewing our health system framework, the Learning Health System Action Framework. We've, since last April of 2024, so almost a year to get through this, spent a lot of time covering what the content is here and what it means in advancing health systems. And this is a framework for not what to do, but for how to do things. And we're going to review today some of the ways we've learned about this. And we're actually going to get a bit of a sense from the people who are participating today, how you are doing your work, or those partners that you're working with. Just for a reiteration, and for those who haven't been with us for all of the events, over on the right side of this figure, you see what we're aiming for, which is a quintuple aim. So we have a quadruple aim of health system affordability, integrated care experiences, health workforces, and population health. And in each of those and throughout all, their equity is engaged as a driver and as part and parcel of each and every one of those elements. Over on the left side, or central in the whole framework, is what we call the gears, the engine of the learning health system. And there are 5 main gears. I'm going to review them all because we've been through each of these gears in separate webinars throughout the past year. And the tiniest little blue things are all the people who are here. They're patients, family caregivers. They're people from primary care. They're all the actors in the health system that are working inside this engine. We're going to have a little bit of an emphasis today as well, because we haven't talked about it much, on the top and the bottom here, which are fuel and accelerants. An engine needs fuel to operate. And we're going to talk about some of the sustainability elements of moving towards having a learning health system that is sustained over time. And so we're going to talk a little bit about those as well in today's webinar. We haven't had the chance to review or visit those. There's a QR code in the corner. You can snap and have a look at our brief, which is published on the Ontario Sports Support Unit website. If we could go to the next slide. And I think I may have already gone through. It's aussi disponible en français. Merci pour le soutien Québec pour faire amener ça. And we have the full brief is also being translated into French. I'm not sure if it's on the website yet, but we're loading it up now. So we are partnering also with our Canadian peers in Quebec on activating the learning health system. So we can be truly pan-Canadian and bilingual in this regard. I'm going to go through just a couple of pieces here. On the next slide, we're going to have a framework, a measurement model against this framework. So I'd just like to introduce everybody. I'm getting a little ahead of the slide where I have the two of us. Oh, maybe I don't actually even have the two of us early on. But I'd like to introduce Dr. Victor Rentes, who is a postdoctoral fellow at the Health System Performance Network and has been working with us with the Institute for Better Health, who are the originators of the Action Framework, to develop a capability, a measurement tool to understand how well people are undertaking the activities that are related to each of the gears, as well as the accelerants. And maybe I'll turn it over to you, Victor, just to outline a little bit of this work.
Thanks, Walter. Thank you for the opportunity to be here and discuss this work. So I'm Victor Rentes, postdoctoral fellow here at the University of Toronto, and along with Walter, the IBH team and the HSPN researchers, we've been working on developing an instrument that supports the adoption of the Learning Health System framework. It's mapped against the gears, and it's meant to facilitate assessments of the extent to which your OHT or any given health system is able to enact these gears, right? And so today, as we go through the slides, as we review all of these gears, we're going to introduce this instrument bit by bit and discuss a little bit about its purpose, how it's structured, the development methods used, some early findings from pilot tests, so if you could click on the next, there's an animation in this slide. If we could go just to the second paragraph. There we go. Just feedback on how we've presented some of the data visualizations with the survey data, with the data we collect with the instrument would be highly valuable as we're iterating the tool and developing an application methodology so that we can standardize an approach to assessing a learning health system's capabilities. And then we'll discuss a little bit on the results and how we can use these findings to improve our capability levels. And so using the survey findings to facilitate the development of learning health systems capabilities. Next slide, please. Okay, so the measurement tool, as I said, is mapped against the 5 gears. As you can see, the 5 gears from the Learning Health System Action Framework. Next. So I'll talk a little bit about what the tool does. So next. So again, it's mapped across these gears, and so it identifies capability levels for each one of these gears, right? The tool is meant to be completed by an interprofessional audience and interprofessional collaborators. So all of the roles represented here in this webinar. So executive leaders, managers, clinicians, QI leads, data scientists, researchers, operational supports, so that we can gather input from a broad range of system actors. People tend to have expertise in their parts of their system and knowledge about what's going on in their areas, but not on the system as a whole sometimes. And so what we want is to gather a broad range of inputs on how well we're enacting these gears so that we can have a collective assessment. Right, and so what the tool does is meant to enable create a self-assessment. So for an OHT or for a health system to assess itself for planning purposes, right, and establish that shared understanding of that current state of development across these 5 gears for planning purposes. Okay, next. Okay, and so how is the tool structured? We've gone through iterations now, and in its current form, it is a survey that has understandable terminology across disciplines. So we conducted cognitive tests with clinicians, with leaders, with patient representatives, with researchers to ensure that the terminology resonates with the audience, with the different audiences. It's generalizable across clinical settings. So we use clinical or clinically neutral terminology. Low measurement burden, it takes around 20 minutes to complete. It's got 40 items in total. Most of them are Likert scale, where we ask people to evaluate the extent to which the gears are enacted in practice, right? And there are qualitative sections where participants have the opportunity to provide open-ended comments on specific barriers or opportunities or challenges, change ideas that could be valuable as we aggregate findings and provide a thorough assessment of your capability levels. Okay, next slide, please. Okay, so I have here a section of the tool to illustrate. This is the first gear, the section pertaining to the first gear, the analytics and population insights. And so as you can see, there's a brief definition of what we mean by that gear. Thank you, Tracy. Patients and public seem to be missing from the to be completed by list. Yes, we'll update that slide. And so the tool has a demographic section at the end where we collect input, and that option is there. But thank you for that. So here we have what we do is we present a series of statements regarding the specific activities to be enacted in each gear, and we ask participants to rate the extent to which they're done. They are enacted across their program or their organization. And so the response options range from we never do this to we do this nearly all of the time as part of the way we do business. That's part of routine operations, which is the goal of the learning health systems, to be able to do these things on a routine basis as part of the way the organization operates, right? And so these are the 4 questions, the first questions in this section. So it's talking about the use of administrative or local EMR data to measure quality outcomes and prioritize patient populations, using patient survey methods to assess experience or reported outcomes, qualitative methods, data modeling. I'm not going to go through each one in detail, but this is just so you get a sense for what the tool looks like. So next slide, please. This is the second part of this first section. So it's still the analytics and population insights. So 2 more questions of equity analysis and whether or not we aim to identify inequities and prioritize equity deserving groups. And actively engaging a diverse array of partners throughout. And then there's an open-ended section where people have the opportunity to provide those comments. So let me just look at one of the comments here. So Susan is asking wondering about that we do this often and we do this nearly all of the time, and are they perceived as similar response options? I understand that all of the time may be too ambitious, but it may be something to strive for. Exactly. So it's that ideal state where we're looking to reach that ideal state where we do these things as part of routine operations, and doing this is just something we do all the time. And doing it often is, most organizations are not at that level of doing this often. As we pilot tested this tool. Okay, I see. So again, Susan, so should the last option be we do this all of the time? That's good feedback. That's good feedback for us to reflect on. It could be, and it's something we're iterating and testing and assessing whether or not what that ideal state looks like. Is it, do we do this all the time, or so that's good feedback for us to think through and discuss. I think. It could be. So let me move on. That ideal state is we doing the things all of the time or nearly all of the time as needed. We do have at the end of the tool a definition for what we mean by each one of these scales, and I can go through that either at the end of the presentation or at a later time, but we have a specific definition for what we mean by each one of these scales to clarify. So next slide, please. Okay, so in this slide, we present the specific attributes that are measured within each one of the gears. So for each gear, these are the specific activities or elements that we are assessing against and creating scores for, right? I'm also not going to go through each one of these. This is just so you have a sense for how each gear is divided into subconstructs that we are assessing against and evaluating your capability levels, right? And so if you look at that 6th column, those are the accelerants and moderators that Walter mentioned, and that is a short list that is representative of those elements, and this is just to illustrate that we're looking at all of these specific attributes within each one of these gears. Okay, next slide, please. Okay, this illustrates early findings from one of the pilot tests we conducted. So we calculated the aggregate mean scores for each one of these gears based on survey respondents, and we're able to assess performance, if you will, or the capability levels for each one of these gears in terms of the scale. Right, and so this, according to the data we collected for this pilot test, the co-design gear has the lowest mean. It could be the largest opportunity for improvement there. And so one of the key objectives of this tool is to facilitate the prioritization of areas for improvement. Right, it is likely that there are opportunities for improvement in all gears, and you want to develop capability to be able to enact all of them. But which ones are the most pressing? Which ones are the ones that are lagging behind and that you need to work on the most? And so we aim to facilitate this prioritization by providing these scores. And so there's obviously variability across the answers, and I'll show you a different data visualization that we've developed that illustrates that variability as well. So I just want to touch on the comments. I see that, okay, Walter is asking what others think. Thank you, Tracy and Kim. So Tracy's saying, I like the nearly reflects real world processes, and Kim agrees. And okay, that's really valuable feedback. That was, I believe, some of the thinking when we created that definition. So I'll move it on to Walter.
Hi. Thanks very much, Victor, for outlining that. And people are going to have the opportunity now to respond throughout here, not to the entire tool, but actually a couple of these elements, and get a sense for the people who are participating today in your health systems, the extent to which you think these activities are being undertaken. The next slide is a bit of an outline. So we're going to go basically back through in pretty rapid fire. We had a full session on each of these parts. So this is the Advancing Learning Health System in 7-part series starting last April, and then in May, June, July, September, and November. We went through all of these. So I'm going to highlight just one or two kind of key findings from each of these. And then we'll come to enablers and barriers. And along the way, we will stop in with the tool that Victor has summarized with some of the key insights and findings. So that's something new that we're actually adding in. On the next slide, we just kind of show you these are the 7. All of these webinars are available, and this one, the last one in the top right corner, will be available on our website within a few days after this event. And some of them have been watched 150 times, but one of them has been watched over 2,000 times now. And so it's just, there's a lot of rich content in these past events and webinars. So I'm going to start with the first one. On the next slide, we had at the very origin, John Lavis and Rob Reed, who both co-lead RISE, along with Maureen Smith, who is our citizen partner in creating the Learning Health System Action Framework that you saw. And then embodying this in practice, Kelly Smith, who's the chair in patient-oriented research at Michael Garron Hospital and the East Toronto Health Partners Network, talked about some of their experience. On the next slide, I just want to highlight a couple of things that John and Rob really talked about. First off is features of a learning health system, and this is in the RISE brief on learning health systems. It's a really nice sort of summary about what learning health systems are and how they're activated. And it's first off anchored in patient and client's needs, perspectives, and aspirations, driven by timely data and evidence, and supported by appropriate decision supports, governance, financial allocations, service delivery arrangements, with a culture and competencies for rapid learning and improvement. That's a lot of things, but actually I think you will see through this that these are activated through the gears and also in the accelerants, fuel, and the supports. Two real things on the next slide, actions at the heart of a learning health system. First is, and this is near and dear to my heart as an evaluator, which is learning and improvement cycles. We test change, drawing on evidence. So are we actually doing evidence-informed change? And involving research operations and patient-family partnerships to determine what does success look like, and being quickly able to measure and feed that back to the programs as they're being implemented. Where the accelerants, fuels, and the brakes and moderators kind of come in, it's this locking in, making change for the better the new normal and not just pilot projects. So that's where we really need to have aligned governance, financial and health services delivery arrangements with both culture and competencies. So bringing these different elements together and locking them in for sustained change over time. Rob, on the next slide, talked a fair bit about different capabilities that are important: data and analytics, evaluation, really having implementation research and behavioral, qualitative insights as well, evidence synthesis, technology assessments, and looking and building in guidelines. So these are the different trades of bringing in evidence and building this up to a more robust, so not the, and people have to have particular training in this. And we'd like to see this kind of training spread across the entire system. But also there are going to have to be experts in this space. And Rob talked about some of those elements and surprising. And finally, Maureen Smith on the next slide. Really, this is something that I am completely embedded in, is that we only succeed when we have a true partnership between patients, citizens, caregivers, health system partners, and researchers. And that truly is the action framework for the learning health system, being embedding all of these three partners. And if we're missing one of them, the stool will tip over. And so it's not, people are not just data donors. You know, earlier in this chat today, there was a question from Tracy that patients and public seem to be missing. That is not true at all from the framework. And a scoping review actually found right from the very origins in the national academies, when they introduced the idea of a learning health system, it's very much patient-centered, and patients are involved at every step of the way. And we really need to ensure that the engagement involves particularly those from equity-deserving groups, and that is not taken lightly, and it requires extra particular emphasis. And actually, in our full tool survey, we ask in each of the years the extent to which people are engaging with more difficult to reach populations sometimes. And some of our traditional ways of engaging with patients, family caregivers need to be modified in order to do that successfully. Okay, we're going to step into the 5 gears. Next slide just kind of highlights. So that was a brief overview of the what it is we're trying to achieve and some of the ways of working. And on the next slide, we're going to start here with analytics and population insights. I'm not going to read this slide. If you want to know more about these, we're going to go pretty quickly. I suggest you go back and look. We had a whole webinar on this with quite a bit of detail. The next slide shows who was represented at that webinar. We had OHTs from across the province of Ontario, Matt Meyer from London, Middlesex, Emmy Perkins from Guelph, Sarah Shakani from East Toronto, and Sarah Grace Bevanek, and they provided different aspects of different forms of data that they used. So on the next slide, for example, Matt Myers talked about, you know, their original data with their attributable population, mostly taken from the Ministry of Health, getting a sense of their overall population demographics, what are the people and what are they facing. And on the next slide, he talked about how they actually narrowed down into supporting some of the top priority populations based somewhat on the total cost, and really appreciating that 8 of 10 of these top 10 really involve people with significant comorbidities. So if we think about heart failure, for example, we've done some work for those of you doing pathways. 83% of the people with heart failure in the province of Ontario have 5 or more chronic conditions, not just their heart failure. And for those people, only 10% of their hospitalizations are related specifically to heart failure or are for the treatment of heart failure. So it's many other things. 90% of their care relates to these other conditions. The next slide, we learned about really taking that data and moving it to understanding, which then is translatable to action. And Emmy really talked about making sure that we are actioning the work. And Sarah, this is from Sarah's slides, East Toronto Health Partners, talking about how do you take that and how do you have people embedded in your OHTs and in the system who can help make that translation happen. And as a data provider, Health System Performance Network has really learned over the last number of years how we are not responsible for providing data. We are responsible for providing actionable data. And that really enhances, we have to bring that understanding to everybody. Finally, the real importance of having patient, family, caregiver data as part of that population data. And so up in South Georgian Bay, Sarah Grace has been doing some really great work in using patient survey data to inform their priorities. So not just relying on administrative data, but really reaching out to, and they're sending a survey out to 38,000 people in their OHT to gather information about their experiences and outcomes. And you can see some of the actions that they're taking that data, turning it to action, of patient tools to support digital health, developing a patient handbook, and very engaging with patients' family throughout their entire journey. So that's just some of the highlights that we talked about in the first, and I'll very, very quickly here, because I think it's worthwhile going back. We have some short videos up on our web, but also just the full piece. We go to the next slide. We're going to ask you now, in your experience, and we've set up the questions here so that everybody attending today is able to answer one of these questions. So using data, any of administrative, medical, surveys, qualitative data to identify where improvements can be, let us know how often you do this. And we have an option down at the end for the people who are not directly involved in the work. So that's fine. I just want to make sure we're checking in with everybody today and getting a sense of the extent to which in your activities we're seeing this, or you're seeing this happen in your OHT. So please continue to check in. And I'm not testing you on how well you answer this question. I'm just going to monitor to see that you do answer this question. So please do. We have more than half the people now weighing in, but I think there's room for, as I said, everybody who's here today should be able to reach the keyboard and answer this question. That's why we put the don't know. So keep going. I'm going to keep pressuring. I can go with awkward silence for a few seconds if we need to have everybody weigh in on this. I really want to have a sense of the extent to which this is happening amongst the participants and respondents today. And I think ask questions if we decided Ellie's a little unsure. Just pick a category for now, and we do in the tool itself provide a deeper explanation of what we mean, because I think there is some ambiguity sometimes. And is it more this? Is it more that? And I think this isn't mercury in a thermometer. It's just the best assessment that we can get. Okay, we're at about 75%. I'm still wondering where the 25% of you who are not answering on here are doing. But let's come out and share out these results. Thank you very much. So we see that almost everybody is doing something here. What do you think, Victor? Room for improvement, but how does this line up with the results that you have had? So we see here, it looks like about 60% of people are in that sometimes to nearly all the time. And actually we have about 16% of the people who are saying all of the time. How does that map up?
Yeah. Can you, I'm sorry, I can't see the results in this.
Oh, okay. Well, it was, it's 2% saying never, 5% starting, 22% sometimes, 17% often. So about 20, sometimes often, and nearly all the time. And then we have about 40% of our respondents are not directly involved in the activity of the OHTs. They're the supports, they're the program policy supports. And you have your own results as well in the next.
Yes. Okay. Let's see. Let's go to the next slide. Okay. So that's excellent. It's a very nice comparison. But this slide will presents. So what we did in this is we drilled down a little bit further into that question and asked the specific activities within asked about the extent to which the specific activities within this year are enacted. So this shows the results for the first year, for the analytics and population insights that we're discussing, right? So each stacked bar is one attribute or one specific activity within that gear. And the blue line shows the mean scores for each one of these attributes, right? So we see the first stack bar is using clinical administrative data and conducting descriptive analysis with EMR data, for example, or other data sets. We're at about a 3 there. So the mean says we do this sometimes. Patient-reported data analysis, a little bit higher, 3.29. Qualitative data analysis, a little lower, 2.43. So in between, we're starting to do this, and we do this often. So similar range. And Walter is adding that this is a pilot result. This is, yes, this is results taken from 2 pilot studies. Correct, 100 and plus respondents have completed the survey so far. And so data modeling, that pertains to predictive analytics and machine learning. And so a little bit more advanced techniques and in data analysis, equity analysis, ability to whether or not we're systematically identifying inequities through our data, and then engaging with partners across these analytic activities. And then the colors illustrate the variability of answers, right? And so typically it indicates the percentage of respondents who indicated each response type. And so red, let's just say, to simplify, red is typically bad, we're never doing this, and blue is good, we're doing this more often, right? And so this type of data visualization can help us identify which are the specific areas within the gear that we're not doing so often, and to help prioritize what it is that we want to get better at, right? And so whether or not we want to improve data modeling in the short term or using AI and predictive analytics and machine learning is something that the team can debate, whether this is a short-term or long-term goal. But certainly equity analysis, for example, was something I would recommend this sample of participants to focus on. We have 43% saying that we never do this, 1.71 mean, so we're in between, we never do this, getting close to starting to do this, but not quite at 2, right? So that would be something that this team could focus on based on this type of analysis.
Yeah, thanks a lot, Victor. And these are sort of being brought here as exemplary of the ways we could ask this in Ontario Health Team. So we just asked you the very general overview question, but actually there are more detailed. And so you can see the more difficult to do things are happening a little less frequency, at least in our pilot studies. But we're trying to find out today what OHTs are doing. So that's part of our engaging with you in this. So keep coming along. On the next slide, I'm going to go now quickly a little bit through our webinar on evidence synthesis. And this actually was our most I think our co-design was the most well attended, but this one is the one that's been viewed the most after the fact. So you'll see on the next slide some of the people. So we had from Craner in the north, Diana Uranek and John Holmberg, how they're supporting OHTs in the north. Justin Persaud talked about a lot of the Ottawa Methods Center and what they have in terms of, and they have a lot of resources for people who are in the East or just generally interested in partnering with academics. So this is part of our idea of OHTs out there are not going to be able to do this entirely on their own. And HSPN has, so much supports, and more particularly in some areas. So, Justin has a lot of expertise in implementation science, as well as evidence syntheses. And then also Killen Mote from the McMaster Health Forum are the largest suppliers of health syntheses in Canada, and one of the largest in the world. And talked about some of the resources that were available there. So in each of them, on the next slide, Craner talked about what their areas of expertise were and things that they have to offer around partnering with the health system, understanding minority and marginalized population systems, learning health systems, an embedded partner in some of the Ontario Health teams, their area around digital and virtual care, especially important in the north, thinking about health human resources, also again with a northern emphasis. On the next slide, Justin talked a lot about the different elements around implementation. He had more than this. He had some really brilliant examples of how they've supported work from the Ottawa Hospital Center for Implementation Research on audit feedback, CB clinical practice guideline, development and evaluation and testing. They also have evidence syntheses and a number of broad array for everything from health economics to qualitative understanding of research. And then finally, Kaylin Moat went through talking about enabling evidence-informed learning and improvement processes. And on the next slide, went through 5 prompts for OHTs to use as you are thinking about your work. So for example, confirming that research evidence is actually what is needed, using a framework to generate mutually exclusive and collectible information to work with that, and then leveraging the right evidence repositories, going to the right sources, and RISE and McMaster Health Forum in particular, one of the greatest sources, knowing what to look for and how to look for it, and knowing where to go to find these evidence support units. So for example, like RISE, Cochrane, others that are available. So this was a real idea of bringing some of the expertise in the province that exists to support Ontario health teams in the area of scientific approaches to the work, both from an evidence synthesis as well as implementation science, evaluation, and even some of the data work in the front and back end. So now let's see for the participants today, go to the next slide, we're going to have another poll about the extent to which you are able to use external evidence and ideas to select and guide initiatives, and then to use and adapt that to your local context so that we understand you're not going to take something from somewhere else. In fact, most things require a fair bit of adaptation. So the extent to which you are trying to draw on evidence in your work, and I say this is one of the things that distinguishes our learning health system approach to PDSA cycles and quality improvement, for example, where there may be evidence that they're trying to implement, but it's not as explicit. We're very explicit about ensuring that once we've identified the problem, that there is a step taken to seek out the evidence and to consider a synthesis of that, and then how it applies in adaptation and adoption into the new areas. So let's see how people are doing. Okay, maybe we could share this out. Thanks a lot, Trisha, I think is doing these in the back. We have Myron helping moving the slides. Everybody's involved here today. So here, this is a bit of a summary of how well people are doing it already. We never do this. There's nobody who says they never do it. That's fantastic. 10% say that they are kind of starting to do it. And then 24, 20, and about 10% are saying they do it sometimes and often. That's the kind of 24 and 20. And then about 10% saying they do it nearly all of the time. And we have some of our respondents today that are not directly engaged again. So Victor, so never is 0, starting to do it is 10%. And then sometimes and often has kind of about half of the participants today. How does that fare out?
Sorry about that. I think it fares up similarly. Why don't we look at the results for in the next slide, and I will show you what our pilot test reflected. So we didn't quite break 2, right? So the highest score the mean score we obtained in this pilot was a 2. So we're starting to do this, right? So this is I believe fairly similar. So again, in this gear, we drilled down the evidence synthesis into the specific activities that we've mapped. So this has so the first one is about defining specific questions that will guide your evidence synthesis and that are aligned with your quality improvement objectives and that are well defined. The use of appropriate evidence synthesis methods and we define those in the survey question. And then the third one is about using evidence synthesis in your improvement and change initiatives. And then the fourth, and this is present in all of the gears. It's about engaging a diverse array of partners throughout your evidence synthesis activities, right? And so in our assessment here in this pilot, we can see that the biggest gap is apparently is in the evidence that this is a method. So in using methods, 71% of people said um, uh, we never do this. And lowest mean score, and there's a opportunity for improvement there. But throughout the year, no one indicated that we do these things often, or we do this nearly all of the time. So this signals that there's a fair amount of opportunity for improvement here in evidence synthesis based on the findings from this pilot test.
Thanks very much. And it's interesting how I think some of the respondents here, if I were to like gauge their activity for those people who are involved and engaged in this activity, our respondents here seem to be doing it more often than some of the elements in our pilot test. So that actually makes me think that a lot of the things that we're talking about in the learning health system are being enacted by Ontario health teams, certainly the ones that are coming to the HSPN webinars and learning about it, which might be a select audience. We totally sidebar anecdote. We've been looking, we do every few years take a really good look at our participants, who they are and what they're coming for. And we have a report that will be released next month on attendance at our monthly webinars. And we won't publish names, but there are about 20 people out there that have been to more than 18 of our last 21 webinars. So I call those the super users. And I do some work in super users. So, but quite good attendance from across all OHTs coming up next month in a report. Victor, there was a technical question. Maybe you can answer it in the chat about the wording. It probably has to do with the wording of the question, such that people would respond. And it looks like I think the response is probably in how people respond to never versus starting to do something, and that people are starting to use evidence synthesis. As opposed to, I'm not sure what the question is that relates to evidence synthesis methods specifically. And maybe you could answer that one in the chat. So we're going to move on. Next slide. Learning Gear 3, patient family caregivers. This was our best attended event. On the next slide, here we had great pleasure. I co-hosted with Carrie Koleski, who's done an amazing, she has a research chair in patient family centered care at the Institute for Better Health. And also has done an amazing job engaging in true and genuine patient family caregivers. We had a couple examples of where people are really doing some fantastic work. So we have a caregiver advisor from Mississauga Health around palliative care, who, if I recall correctly, has survived 2 spouses and has had a lot of experience in palliative care in Mississauga. And then both clinical and executive leadership for that program and how they really do that co-design in the palliative model. And then also from Midwest, where they've been doing some really excellent work, particularly around mental health. But Yasmin Shakan's co-chair for the OHT, and she chairs the patient family advisor, and she is a patient advisor herself. So one of the things Carrie talked about on the next slide are a number of steps. So 6 key stages. Building relationships is where it starts, and to really emphasize that. Then having a clear plan of how you're going to get the work done, exploring, developing, deciding, and making change happen. And she went through each of these steps and talked about it in some detail with examples about how they've enacted this in practice. Carrie, on the next slide, has developed a number of additional supports with the support largely of the Ontario Sport Unit. They have a whole series of workbooks as well as videos around this. And there's a course that has been developed in this space. And so we recommend that you go back, you can see what Carrie had to say, and then there's a whole other universe to be explored through this series, as well as additional workbooks to engage with. On the next slide, we heard from how it was that Mississauga was going about doing their work. So starting off with some references that are available to everybody through the Ministry of Health, Patient Family Caregiver Declaration of Values, basing their work on that, and then actually having a very specific handbook that they're using with the community, developed by patients, family caregivers in the Community Health Advisory Network in Mississauga to create that space, and really some exemplary practices that they summarized. On the next slide, we actually saw some of the activation of this in the Midwest OHT, and this is actually comes back to some of those definitions that Carrie talked about, discovering, defining, designing, and delivering. Not exactly the same words, but quite similar. So, but understanding the problem space and the solution space and how they work with users and patient family caregivers and community members in each of these phases and stages. And they've done some really excellent work in embedding that. So I'm going to turn now to people participating today. On the next slide, we have our poll for this year. We're about past halfway through now. We want to know around this co-design and engagement. If you could let us know in your experience, how activated are you in this space, in your OHT? And again, if you're not participating in an OHT, please don't sit back. Please click in and let us know that you're not directly engaged, so we can just make sure we're having people engaged. And I will come back and monitor the responses that are coming in here. Again, this is fundamental work. It is actually one of the principles. We have a number of patient family caregivers on the online today with us, partnering in this work and have been with us many of the steps along the way. So now we're coming up. Okay, so we actually are doing a little bit better on responding to here. People, I will gauge by the response rate how much people are engaged in this work. So if we could share those results out, awesome. So only like one of our participants today saying they're just not seeing this happening. About 15% Victor seeing, because everybody else I think is seeing this result except for us on the panel. Starting to do it, and then 20% doing it sometimes, and then 10% up at the often and nearly all the time. I'm actually a little surprised not to see this more activated in this space. And so clearly, actually, this is an area for greater improvement. Even though I would have thought that many OHTs, because we've seen it certainly, and we've highlighted it through many of our webinars where it's happening really effectively. There's more opportunity for improvements here. With here of the active respondents, more than half saying we're just starting and we're doing it sometimes. We haven't really locked this in yet. What do you think, Victor? We can move to the next slide too to show your results from the pilot.
Yeah, let's do that. So, yeah, I think our poll, if we were to calculate the means, it would indicate something a little similar to this, or maybe slightly lower. What we had in our sample here is a little above 2. So the mean score for engaging with partners for co-design, that's our first activity in this gear. We believe that is the key component, the most important aspect of co-designing is engaging with the diverse group of partners that are representative. So 2.29 in our sample. And then using co-design methods and techniques, we got a mean score of 2 with some variability. And then the last one, it's about this activity. So mitigation of participation barriers and ensuring that power imbalances are explicitly addressed. And so that's the one we see the most variability in our samples responses, right? And so if you were to prioritize here, I would potentially focus on co-design methods, and the third one we have a 2.29 mean score, but there's a wide range of variability. So 14% of people said we do this often. No one said we do this nearly all of the time. But that variability might indicate that in some areas this might be occurring in the organization and others aren't. And so in other pilot tests, we were able to compare these data across different programs within the health system. That's important to be able to assess where it might be the case that in some areas, in some programs, we're doing this often, and in others not so much. Does that make sense, Walter?
Yeah, I think so. And again, lots of opportunity for improvement here. And this actually looks a little bit better than the evidence in terms of this particular the pilot audience for the pilot studies. But I think that understanding in the OHTs where the opportunities are, and I would certainly like to see this happening nearly all of the time. Particularly at least up front in the engagement and co-design. The rigor comes along, I think, with experience and techniques. On the next slide, we're going to step now into implementation. And here is, as I mentioned earlier, evidence putting that to the forefront. But here's another area where I think the learning health system is more attentive than quality improvement. And that is having really specific thoughts around implementation and using examples like there are many frameworks around implementation, but a behavior change, theoretical domains framework. And so really applying these. And we had an excellent example. The next slide shows in this webinar where Tina Fahim, Marjorie Hammond, and Jeanette Cooper talked about frontline experience of how they went about implementing a practice change. Their example was around hip fracture and particularly around pain blocks in the ER. I've seen others now replicate this out at Trillium, but it was a really great example of how to do this well with frontline staff. And Marjorie Hammond's a geriatric nurse, and I have seen this now happen in other examples of really doing this. The next slide talks, Tina gave us a bit of an overall framework that really she thinks about this as fitting it in of knowledge to action. And this is the Canadian Institutes for Health Research knowledge to action model. And they're like identifying the problem, adapting knowledge to new context, all the way around to implementing and tailoring and sustaining that knowledge use. This is Ian Graham's work. Also with support from Sharon Strauss, which is also where Tina Fahim works. And then we see on the next slide what they did, and this is something I think people can really make use of, is this is a behavior change wheel thinking about why would people do what we want them to do, and why are they not doing this more often? And it talks about capability, opportunity, and motivation. And there are a number of elements, and one can actually break in and start talking through what we need people to do, maybe what we need people not to do, and understand. So they really talked through this example, and I think it was very, very helpful. On the next slide, they showed one of their papers of how they explain this, and I think it's a super, they have a few articles around their implementation that are useful. And here they're really clear about know your what, know your who, understand the why and the how, and then building this in and planning. And this can't be done with some group that are not involved in the implementation. Implementation has to be designed and built with the people who are actually doing that implementation. Okay, so we want to know how much you are actually having a diverse array of the people in your space. So if we go to the next slide, how much are you really understanding what drives behavior as you're looking to implement change? And we're really seeing a shift in the Ontario health teams now from thinking about planning change to implementing change. And so how much are you, as you're trying to make things happen in the implementation, paying attention to these, understanding what's driving the behavior, and thinking about the barriers to the implementation? Often in our evaluation work, which we do quite a bit of, we use something called the RE-AIM framework, and the first thing of RE-AIM is reach. So do you get to the people? But really interested in the activation and whether the programs are actually being put in place as intended. And very often, people think of a great idea, and there are many reasons why these great ideas aren't being done. So how much thought and what's your opportunity to think about being able to bring that forward? So thinking about implementation, and again, this is a space. I think sometimes we have a lot more just knowledge sharing to do in this space of bringing it up to speed and bringing people up. So let's have a look at the results here. There's a bit of fewer people actually responded to this question, so I think people are even just wrapping their heads around what the question is asking. So I'll take that as a bit of an indication right there. So lowest response rate so far, about 50% of the respondents. And we're seeing, a couple people never doing it, some people starting. The most often is actually people doing this often. So people are thinking about this. It's about 22% of the respondents to this particular poll. I got to say, people who are not involved in OHTs are being more responsive right now than the people who are involved in OHTs. On this particular one, they got just over half of the respondents, but doing it nearly all the time, only 8% of the respondents. So this is, leaning positive, but a lot of people didn't answer this one, and I think that might be even just understanding what the question is asking. Victor, how do people do in your pilot study?
Let's look at the next slide then. So here are the mean scores. Again, we separated this question into specific components of implementation. So the first one is about that alignment between the solutions that we co-design and aim to implement with the values and the workflows of the people who will be impacted by change, right? And so we're really trying to get at that alignment between the solution and the context in which it is to be implemented. So a score of 3 means we do this. We're doing this often. So some opportunity for improvement, but overall, that's been perceived to be enacted well. The second stack bar is operational support for implementation. So whether or not we have the expertise and available supports and staff to facilitate that implementation action and projects. And so engaging with frontline providers with that implementation expertise and providing adequate technical and technical support. The third stack bar is about leadership. So whether or not leadership provides the adequate resources, but also accountability, incentives, time availability. So whether or not that leadership, both the quote unquote soft and hard aspects of leadership are there to support implementation. That's a 2.86. So in all of these, we're sort of in between starting to do this and doing this sometimes, which I think is a little lower than our poll indicates here. And then the fourth one is engaging with partners for implementation. I think that is the most, that's the question that most aligns with the poll, and 2.3 in that, and we have 14% of people in this pilot test sample indicating that we never do this. So that could also mean an opportunity there to focus on ways that we could engage partners a little bit more during implementation initiatives.
Yeah, thank you very much. And I think that's really important that the patients are mostly and very much engaged in the implementation. I say if we don't have patients involved, things will not work. Just like if we try to implement ideas without considering how providers are structured and what their incentives and opportunities are. The last gear, per se, it's not the end of the framework, but the last gear is around evaluation, feedback, and adaptation. So if I say this is an area of strength for the health system performance network, this is something we do day in, day out, supporting overall evaluation of Ontario health teams, supporting the leading projects most specifically right now, but we've also had roles and activities within other types of programs and projects. So we kind of do the upfront data and analytics, population insights, and we work in this space as well. And those are our strengths. And then we have good partners for supporting other work. But we had some amazing examples across the OHTs on the next slide from Doctors Catherine Donnelly, Rahim Abdelhalim, and Brianne Wood from different parts of the province who are supporting evaluation feedback in different Ontario health teams, all with a similar premise, actually. On the next slide, I mean, I introduced originally supporting this work with a logic model and a starting point, and we have online resources online resources related to building logic models and how you use this to help drive change. And how do you help this to set up your measurement, your reporting, and a whole evaluation framework starts here. I was very pleased on the next slide that you can see that all of the other OHTs that were participating put up logic models of the things that they were doing. So we didn't support this work. This was done. This one's from FLA, but they were common across all of them. And this was for one of their programs, Aging Well at Home. They have their vision, shared purpose over on the right side, that impact statements, the outputs, the things they're actually going to be counting and marking along the way, the activities that they need to be doing through the different elements, and who is going to be doing what over on the input side. What resources do we need to bear to bring this in? On the next slide, it's not just enough to have that framework, because lots of different things happen along the way, and needing to adapt in real time the initial plans and that flexibility and tailoring of the intervention before getting to this question of did it work? And then we had some kind of key findings of the adaptation in particular on the next slide from Brianne in the north, sharing the work and bringing others along and using resources widely being really essential for the teams in the north, and what was how they had to work differently together, and not only thinking about what they were doing, but how they were going to build capacity within their own people in order to be able to do the work well. And that's really part of the strategy. Not always having data flows that measure what you want and need to measure. And so data collection is part of it. And people all need to accept this a little bit, that if we actually want to know if we're accomplishing what we intend to, if we want to know whether we're achieving the successes we want, some data collection is almost for sure inevitable. As an example, we have very little patient experience data collection in the province of Ontario, and patient experience is probably the first thing you can have an impact on in your OHT. And then knowing your so what, committing to the action, how are you going to use the data? We talked in the earlier webinar, particularly around Sarah Grace, I mentioned about using the patient experience to drive the changes that they were implementing in their OHT. So this is, we have many, many webinars related to evaluation, or go back and have a look at some of them. We have other resources. Kaylee's put some stuff in the around the community practice, which is monthly, and that's really where we dive deeply. And with OHTs, it's run in a meeting format. There's a lot of exchange. Everyone can be on video and voice and come out and speak, and we see a lot that's kind of enabling that sharing. So this is the last of the gears poll here. I'm going to put up now to see how much you are doing this in your work, formal processing with ongoing data, and this frequent cycles of evaluation and feedback. So how much are you doing this? And we look to support this and support all of the OHTs in being able to do this work effectively. And so here it is that we are coming back and asking you how often you do this in your OHT. So people are filling in their responses in the space, and it's what is sometimes or often these are subjective categories. We didn't say 17 times out of 20 or 3 times out of 4. So just pick what you feel is reflective of your work. Okay. We always lose a few people at the hour, so we're down a few people. So why don't we share these results out now, and we can see that very few people are never doing this. A good number are starting to doing it and doing it sometimes. And people really haven't built this in yet. Only 11% of the respondents here saying we do it often, and nobody saying you do it nearly all the time. And so there's work for us to do at the HSPN to support your work in evaluation and to make this easier for you to do. I hate to think people are putting massive amounts of efforts into doing things and not knowing if they are achieving their goals. And if you are measuring and reporting and providing that feedback, then you know whether you're doing it. And that's kind of what this is all about. How did our respondents feel about this, Victor, in the pilot?
Okay. I think the pilot performed slightly worse. There was no participants indicated that they do this often, or nearly all of the time. So we have these mean scores. Again, we drilled down on the evaluation aspect, on the evaluation gear. So we asked about evaluation methods specifically, and whether or not those methods are robust and rigorous in being able to capture the right data and assess those outputs. We asked about evaluation agility and frequency. That received a 2.29. So evaluation methods, there's just a significant opportunity there. It scored the lowest, so that's something we might want to look into for this sample size. And then let's go to the third one. So using evaluation findings to change practice. 2.57 has scored the highest, but still 57% of people said we do this sometimes. There's opportunity for improvement across the board here in this sample size, with these participants, right? Scope of evaluation, whether or not we are evaluating against the quadruple aim with an equity lens, and whether we're measuring all of these dimensions that we want to improve on. That's what that fourth bar is getting at. And again, engaging partners for evaluation. So there's opportunity for improvement across the board here with this sample. I want to iterate that this is meant to be an to illustrate how these findings are could be presented, right, with this tool that we are iterating and developing. So this provides you with some an illustration for how we could do this for your OHT if we were to assess. We use this tool and assess capabilities against the framework. But yeah, back to you, Walter.
Actually, I'm going to leave it with you, Victor, because I asked you to say when you have your tool, you also have feedback from people about commentaries, because these are structured
Yes.
questions that people have to answer into. And we often say, what else do you have? And you might like summarize how you asked that question. I'm sure on the next slide, I think you had included some of your responses. Maybe we can actually, I don't know if looks like you're stepping through these. So
Correct.
had all of them.
Yes, correct. So Myron, if you could click on the animations, all of them, I'll go through. I think they're a little clunky. I had meant to have these appear one by one, but here's, so in the tool, if you recall, when I presented the tool, we allow for people to provide open-ended comments. So we provide that opportunity so that people can provide statements and comments. And so for each one of the gears, we collect, valuable statements that highlight some opportunities and strengths, which we can then translate into potential action plans that as a team, we can then prioritize afterwards. So for example, for the analytics gear, participants highlighted inadequate staffing and high turnover. So for example, for work that impacts my area, inadequate staffing and lack of succession planning has been one of the many barriers for researchers requesting data for scientific investigation. So that's a people-related problem with analytics. And so some of the actions we could investigate is we could pursue our exploring what the root causes of that high turnover could be. Maybe develop a succession plan and resources to facilitate new hires or training materials. So that could be an area of focus so that we can ensure that continuous ability to use data and collect data and mitigate that high turnover, for example. And so other things that people commented on were lack of resources for qualitative data analysis, and not just not just opportunities or weaknesses or negative or even barriers, but people also commented on successes and strengths. And so for the evidence synthesis, one participant highlighted that they had a robust approach and process for developing guidelines and recommendations, with expert panel step and including patients with lived experience. And so that might be something that we might want to disseminate. And so that best practice could be disseminated across. This was a large organization. And so disseminating those best practices that have been developed in specific programs and areas could be a good strategy to enhance performance and breaking silos, right? So disseminating those best practices, and then for the co-design, the last year we heard there was an opportunity to engage with diverse with patients, families, and caregivers, and that could be an opportunity here for us to pilot test and figure out how to do these things, how to co-design with patients, and then disseminate best practices. So a lot of the issues can be addressed by action, right? How do we if we're not doing so well with co-designing with patients, let's figure out different ways of doing this and then learn from our co-design efforts.
So I think a couple of things here, Victor, is I really appreciate that actually when we did this in the pilot test, your insights that came from these more qualitative responses were sometimes more informative than the survey responses themselves, because they really help direct the action and what meaning people put into, interpretation around their responses. So the responses prompted thinking was expressed here, and then thinking about what are some action ideas and action plans related to this. It's a real engineer's thinking about making this systematic and embedding processes in place. So it's been really been thankful to you for having developed the tools so we can start to understand capabilities in this regard. We think there's a really strong opportunity for people to start to use these approaches that are embedded in the learning health system to really make change happen successfully and to do so reliably. Thanks very much for sharing. So we're going to move away from the gears now, and we had talked about some of the elements here about fuel, accelerators, moderators, and brakes. So if we go to the next slide, just highlight this is what the learning health system accelerants, moderators, and brakes are. And so I can't go through all of these in great detail. I actually could have run an entire webinar on each of these. And we are going to come back actually to looking at these maybe more generally, like what does leadership mean in OHT as it relates to enabling a learning health system as well as other activities. But you see here, having a cadre of patient-family caregivers through your Patient Family Council, or in Mississauga, it's the Community Activation Network, the Community Health Activation Network, so that CHAN, having people that are engaged and involved all the way along the way, having community partners that you're working with. These are fundamental supports to be able to do co-design. You can't just open up co-design and say, hey, we're going to invite a couple of people. No, you really need to have relationships and start and build that. And the investment that goes into creating those relationships, you want to sustain that over time, and it will really empower. All of these things are really about things that you will use to empower and accelerate your capabilities to make change happen. That's the purpose of the learning health system is to make improvements and change happen. If we go right back to the very beginning, engaging with Indigenous groups. And I know that some OHTs are doing a really, really powerful, some are led by Indigenous groups. Then other equity deserving groups also different. It's not the same. They're grouped here together. That's not to distinguish, but more about just how much space we had on the slide when we designed it. But different engagement strategies for different groups. That's our intention here in our thinking. The health workforce needs to be engaged. There needs to be a way and a process by which the health workforce and patient family caregivers understand the learning health system. And resources are being built now to create more knowledge translation. We have the summary, which I showed at the beginning, but also what are the specific messages and how do people get involved from the different angles. Then there are other infrastructures that really build a sustainable infrastructure for the organization to move forward. Having access to scientific expertise, having appropriate and dedicating appropriate funding to this work, having the data and technology insights, and in an ideal world, that data technology is population-based, integrated, and interoperable data systems. That's our ideal state. So how much are we building towards that? What e-health, m-health tools are we actually starting to accelerate and align towards this work? The other piece around, building health system capacity, we're part of building health system capacity. This webinar is part of building health system capacity. Identifying change priorities, those are more external. The top fuel accelerants, we think, are a bit more things that OHTs build up themselves. And the bottom, these accelerators and moderators and brakes, are things that the system needs to support. Ensuring that laws and regulation enable the activity of the learning health system, ensuring that privacy enables the sharing of data, ensuring that governance and accountabilities are set to support this work. And I think also ensuring that ethics, which may be internal to organizations, but it's really about this line around quality improvement and ethics, and it's unethical not to make change happen. And so how do we ensure that as change happens, people have choice, and as data are collected for evaluation, that people are consented, and we're not doing things to people, we are doing things with people, and being supported by them. So there are so many things, but really these elements here are about the infrastructures and the supports to make this sustainable and scalable. You can do a project with just a bunch of people and some willing interests. But to really sustain, you need to start building in these infrastructures. And in fact, to my knowledge, the only program in the world, Victor actually comes from it, where we have a graduate degrees in learning health systems. It's actually about infrastructure and learning health systems because it's so important to be able to actually sustain this and build it. So I'm just going to ask where people think your strengths and capabilities are right now, and your weaknesses. So we have just two counter polls here, last two of the day. So the first one is about the strengths. This same list of options is going to come up next poll about where are the opportunities for improvement. So here, check all that apply where you think Ontario, and not just your OHT, where you think Ontario is doing well. Do we have the leadership to support this? Do we have sufficient patient involvement? Do we have sufficient community engagement, either in your local or at scale? Are you engaged sufficiently with Indigenous groups? Do you see this happening? Do you see there being direct lines of support to the scientific and research expertise that you need? Do you have the data technology that you need? Checking all the ones that you think are a strength in your work. So here we go. As people have the opportunity to click in multiple times, we're going to leave this open just a little bit longer this time. So here are the strengths of your teams where you think and maybe for 5 more seconds, click into those ones, and excellent. I actually think that the results here are best placed in comparison to the results on the next one, but let's share these results out. And from the people participating here, leadership, patient involvement, community engagement are being the top 3 strengths. And then engagement, Indigenous groups, and scientific research and governance being the next. And then finally, privacy funding and technology being a strength in some cases, but far less often than many of the others. So still opportunities there. So now on the counter side, I actually want you to point out the opportunities for improvement. If we can go to the next poll, which are the opportunities for improvement on these same things? And you might be doing well and see it as a strength, but still have it as an opportunity for improvement. You can actually definitely have both. As Victor's gone through and shared up all of the results, even where there were relative strengths in our pilot studies, there were always many opportunities for improvements across all of those elements. So here we go. Let's see, where are there opportunities for improvement? Okay, so here we are. And we have, I guess people knew this was coming, so they're a little bit quicker with the responses this time. That's great. Ready to respond. Okay, so let's share these out. So also a lot of room for opportunities, but I will say data technology and funding, which were lower on the other end, are the top two here that would enable and accelerate the learning health system activities. So those are the top two. But still lots of room for improvement on patient involvement, community engagement, leadership. In fact, across the board, people seeing less opportunities for improvement around privacy and governance, and yet they were not actually areas of strength. So that's interesting. So maybe people are saying, we're not doing that well, but we're not quite sure what to do about it, particularly in the privacy respect. So again, privacy does need to respect people's right to privacy, particularly around personal health information and its use, but it also needs to enable, and there needs to be responsibilities, I think, for sharing some elements as necessary to advance this work. Last poll, bring this down. We're bringing it home. We've taught up a whole bunch of surveys to you today for your participants. I want to know if you think it would be useful or worthwhile to use a survey to assess and report on OHT capabilities for adopting a learning health system. So you've been through this today. You stuck with us to the end. And so I'm going to say, but we've asked you and you've had to respond a number of times along the way about where you're acting. So do you think that this is actually useful kinds of information that we could be asking about? Or do you think that would be kind of like, yeah, leave it to another day because no one wants to answer another survey? Okay, we are short on time. So you have 5, 4, 3 seconds to respond now. 2, 1. Okay, let's share up these results. So no one's disagreeing. That to me is interesting. That strongly agree to agree. People have some agreement here that this is a useful activity. So that's very interesting to us and gives us a little bit of motivation and sense. We have another leadership survey that is going out in the next few weeks. We've started to socialize this, but for people who are leaders in the decision-making councils, you'll be receiving a survey. We are always conscious that we use the data, so we wouldn't do this until much later in the year, but we'll keep it in mind that this may be coming your way to assess the strengths and capabilities of Ontario health teams to advance the learning health system. We constantly encourage your participation in our webinars and all of the activities that we do. We appreciate your joining us today. If we were to go ahead to the next slide, 2 ahead, actually, we're going to pass by these. I really want to thank the 24 people that I represented today. All of these people spoke at our webinars since last April. They spoke from across the province. They spoke from the work that they've done in and out across the years, in the many years that they've been involved in supporting Ontario health teams. And this is a sampling of this year in the last 8 months, people who have come on to share your information. Their videos and what they had to share is available online. You can go back and watch those videos. There are many, many snippets as well in our short video excerpts, which identify the people and the topic. that people are talking about, and you can just go in and just listen for a few seconds or a few minutes on some of them as well. Next slide. We welcome you here every month on the fourth Tuesday of the month, except December and August. But in February, we've been involved in an international study with 20 countries collecting patient-reported experience and outcome data from the OECD, supported by the OECD, that was called the Patient-Reported Indicator Survey, or PARIS. We also have been doing some very large-scale patient experience and outcome reporting in a couple of our OHTs. We're going to bring this to you next month. The Paris results are being released internationally in Lisbon by the OECD on February 20th. So our webinar comes in right behind that, the fourth Tuesday of the month. It's around the 25th next month, I believe. And so welcome to come back and join us. For today, the next slide has our little bit of QR code that you can click on and let us know. We have 3 very simple questions that we ask in this. We really look forward to being able to help design and advance the work of the OHTs through our webinars, as well as all of the other activity that we do through indicator reports, data, evaluation supports, our community of practice. Thanks to Kaylee. I'd like to thank very much Victor for joining us today, and Tricia and Myron for moving in the background to keep everything moving along. And for the participants today, I really appreciate your joining. Evidence synthesis and evaluation for supports from Tracy. Any other suggestions you have, and looking around to more supports, let us know where we can help, as well as the other supports groups. Thank you very much, and have a lovely rest of your day.